Good evening, everybody, and welcome to our premier performance of our FLCCC Alliance weekly update. Once a week, we're going to be telling you what's happening in treatment of COVID that our doctors know works. We will be here for about 30 to 45 minutes to give you information and to answer your questions about COVID prevention and treatment. An important disclaimer first. As we discuss this information today, please remember that this is not medical advice, that we are not making final recommendations about how you or any particular patient should be treated. All of that depends on your specific medical situation, so you have to talk to your doctor. Just remember that. But what can you expect from us? A short welcome from me. I'm Betsy Ashton. I'm the creative director of our growing FLCCC Alliance. About 7 minutes, I'm going to give you latest updates on effective treatments, the news that's going on today, developments. Then you'll have about 10 to 15 minutes, maybe a little bit more, from our Dr. Pierre Corey, a critical care physician, medical textbook author of many published scientific studies, and of course, the president of our FLCCC Alliance. Tonight, he's going to explain the protocols to you, the protocols that we know alleviate suffering and actually save lives. Then we're going to do the Q&A. We are going to take your questions, and Dr. Corey will answer them, as many as we can get to tonight. Now, look at the bottom of your screen and you'll see that Q&A button. If you have a question for us, write it in the Q&A, and that's the way we'll get them and we'll be able to answer them. Not the comments button. Now you can add a comment if you like. We'll read them probably after this program, but if you want something answered, write it in the Q&A. Now for the update. We have 6 items for you tonight. First of all, we want you to know that the NIH updated its guidelines on ivermectin that removed the restriction that they could only be prescribed in clinical trials. So now it's up to any medical doctor to use his discretion to whether or not to use this drug for COVID. This happened on January 14th after our FLCCC doctors presented the data along with Dr. Andrew Hill, who is collecting data for the World Health Organization's consideration. Second, our review manuscript on ivermectin passed through 3 rounds of peer review, with 2 of the reviewers being FDA scientists. This has been accepted for publication in Frontiers in Pharmacology. It is in press. We anticipate formal online publication within days to a week. Stand by for that one. 3, we are proud that our work in highlighting the evidence of efficacy of ivermectin in COVID-19 appears to be spreading worldwide, as evidenced by ivermectin becoming incorporated into numerous country and regional guidelines, particularly in the last 1 to 2 months. Some of the many notable recent adoptions are these: Belize on December 18th, Egypt, November 30th, Guatemala, January 23rd, Lebanon, January 27th. Mexico's Social Security Institute approved early treatment kits for use in many outpatient clinics on February 3rd throughout Mexico, and also for use in the state hospital in Mexico City. Nicaragua approved it on January 25th. North Macedonia on January 15th. Slovakia, the first EU country, on January 27th. South Africa for emergency use on January 27th, and Zimbabwe on January 28th. Next, on February 2nd, Unitaid posted the following statement. Ivermectin, as well as other repurposed products, has been suggested as a potential treatment for COVID-19 based on preliminary promising evidence. Further data is needed to support a definitive recommendation either for or against its use for COVID-19. But promising evidence. Unitaid has collaborated with the University of Liverpool to conduct the preliminary desk analysis of existing trials evaluating ivermectin in different countries in the world in order to facilitate a review by the World Health Organization. The preliminary analysis has incorporated data from randomized clinical studies that have been completed in Bangladesh, Egypt, Iran, India, Iraq, Lebanon, Pakistan, Turkey, Nigeria, Argentina, Mexico, and Spain. In the coming weeks, results from additional trials in other countries are expected, and an in-depth analysis will be conducted by the WHO to determine the next steps, including the potential need for further targeted clinical studies. 5, we have recently received word of increasing numbers of trials reporting positive results. No formal data yet, but preliminary news are that there are 5 more randomized controlled trials of varying sizes reporting various significant benefits with ivermectin use. We hope to have more precise and formal data in the coming weeks. And 6th, Juan Chamilla, a data analyst who's a member of our alliance, has recently completed a manuscript along with Jennifer Hibbard and David Scheim, which masterfully uses epidemiologic data proving the efficacy of ivermectin in controlling the pandemic throughout Peru and other regions. We invite all to read this paper, as we believe it will prove to be a landmark historic paper. Its conclusions are incredibly powerful. And finally, I just want to say something. We are in the process of producing a number of videos. I've been interviewing a lot of people, and we have a film crew that's doing a fabulous job of editing. You'll be seeing them soon, of physicians and patients telling their stories of dealing with their personal experience with COVID, finding out about our protocols, going from nearly dying to remarkably recovering. These are amazing, true, and important stories from people like you who contacted us, many just to say, thank you for saving my life. It's amazing. You'll hear more about that later. But now let's bring on our medical expert, who also happens to be a great teacher. For our first webinar, we decided to start at our foundation, which are the FLCCC's treatment protocols. And our Dr. Pierre Corey will give us an overview of the components and the rationale and the applications of various aspects of our treatment protocols. Dr. Corey.
Hey, Betsy, thank you. That was great. So yeah, it's time to chat a little bit about our protocols, and I'm really happy to be here. You know, I've been saying yes to anyone who's asked me to speak on ivermectin or on COVID for months, and this one's special. It's like home court advantage, right? This is our little house. Look, my fireplace is going, right? We are ready to go. So I figured we'd start with us, right? Everyone knows, I think, who we are, especially if you're on this webinar. But I never try to miss an opportunity to call attention to Paul and how he's kind of he's El Capo de Tutti Capi. So he's our leader. He's the one who brought us all together. Also, I want to put a shout out to Eric Osgood, just an awesome hospitalist. He's half an intensivist. He's always in the ICU, and he's just been a great alliance partner. He's really recently more formally joined us. But on the left, those are the 5 doctors that made up the core of this group, and then some of our supporting physicians and advisors. And so it's a good group. And I just want you to know, these are kind of our core members. So anyone listening tonight, please, I want you to know to join our alliance. This looks like a weird slide, but this is just a screenshot of our website. If you go here, network and support, and you go to join the FLCCC Alliance, we have just a short form. If you support us, if you practice medicine like us, if you use ivermectin, we ask some of those questions. We just want as much support as we can, and also allows you to get updates from us, and also invitations to this webinar. And so, this is from another talk. I just figured I'd go over a little bit of a timeline of where we started, right? So that was our group. We came together in March, our first protocol, and that's what I'm going to talk about tonight. Just a little preview, guys. I'm going to go over our Math Plus protocol, which is for the hospital, so more for the physicians out there, and then iMask Plus, which is our early outpatient and prophylactic protocols. But we started first with Math Plus, and so this is what happened back in April. We saw this thing coming to U.S. shores, and we got together as a group. We're all pretty well-known scientists and physicians in our specialty, and we came up with the Math Plus protocol. And that's what I'll talk about tonight. In fact, I gave a Senate testimony back in May. And at that time, I don't know, I guess I'll use the term, I screamed at the world that you got to use corticosteroids, that it was critical for this illness. And we knew like 5 different reasons why corticosteroids were critical. And just to let you guys know, the entire world at that time were against the use of corticosteroids. The WHO, the NIH, the NHS, everyone was saying don't use it because they had a misunderstanding of prior pandemic medical literature, which we did not. Dr. Maduri had reviewed all that literature and showed that corticosteroids were absolutely life-saving. And his paper, which was published in April, testified to that. Anyway, I went out in the Senate at that time, roundly criticized afterwards until about June 16th, when the recovery trial, for those of you who knows what that is, the Oxford group in England, they did a big trial and they showed that corticosteroids were indeed life-saving. So we were right the first time when we came out and spoke publicly about ivermectin. I'm sorry, about corticosteroids. And I'll get to the second chapter, which is ivermectin. But let's first talk about sort of corticosteroids, whoops, misspelled there, corticosteroids, and also Math Plus, right? So that's our first protocol. And I just got to be clear. I get this opportunity to talk freely about the stuff that I want to make sure that people understand. But I cannot tell you how much chest pain I get talking to physicians and radiologists and everybody who calls this a viral pneumonia. Listen up. It's not a viral pneumonia. It's what's called an organizing pneumonia. Organizing pneumonia is this organized inflammatory reaction to something which triggers an injury. So it's basically a response to an injury. So it's the viral debris, and we have this really intense inflammatory reaction to the virus and the debris. In fact, in autopsies, in very few patients do they find what's called viral cytopathic change. So it's not the virus that's invading and damaging the lung. It's this really robust response, and it's called an organizing pneumonia, and it can be very highly accurately diagnosed on CAT scan. And these are called ground glass opacities on CAT scan. And this is rather characteristic of an organizing pneumonia, meaning very well demarcated in the periphery. These are non-anatomic planes. And the only thing that does this is, I shouldn't say the only thing, but one of the only things is organizing pneumonia. And so since March, the radiologists have said this. So Jeff Caney right here, my partner who I wrote this paper with, I started writing this paper in April because I saw that this was not a viral pneumonia, it was an organizing pneumonia. And the thing about organizing pneumonias is the preeminent treatment, the gold standard therapy is corticosteroids. That's how you treat organizing pneumonia, with steroids. And so we knew that. We knew this was an organizing pneumonia. In fact, Jeff Caney is one of the top chest radiologists in the world. He was the lead author of the expert panel in the journal Radiology, which did the first review of the CAT scans from Wuhan. And in that paper, in March, they wrote the predominant pattern of lung injury on these CAT scans is an organizing pneumonia. That was in March. Exactly nobody listened. Exactly nobody listened. And so I just want to make that point. If you guys aren't convinced of it yet, I want you to be sure that this is an organizing pneumonia. It's a pandemic of it. And that's one of the reasons why steroids are indicated. There's other reasons why steroids are necessary, but this is our Math Plus, and it really centers around methylprednisolone. And let's be clear on my other little soapbox. Not only is this disease called organizing pneumonia, but this disease really requires methylprednisolone, not dexamethasone, and I will explain that to you why. The other thing is we use higher doses. You don't want to hear me, well, maybe you do want to hear me talk about this recovery trial. So the recovery trial, although it saved the world from itself because it proved to everyone that corticosteroids were critical, it did it in the worst way. It used an anemic regimen, 6 milligrams of dexamethasone. I'm a lung specialist. I give 80-year-olds with COPD more prednisone than that, and they're not dying on a ventilator with whited out lungs. And so 6 milligrams of dexamethasone is a ridiculous dose. It's ridiculous. It's what I call helps the few and fails the many. These patients require much higher doses of corticosteroids, and I'll show that to you in a second. So what do? We generally, and we've kind of evolved, is what we'll start out with a mg per kg, which is called 1 milligram per kilogram. We start 80 milligrams, we give it twice as a bolus. Then we give a dose, 40 milligrams twice a day. And that's really for someone who's on modest amount of oxygen. Now we've learned that once you're on higher amounts of oxygen, so anyone on 0.6 or higher, we go to pulse doses, and we do 125 to 250 Q6, depending on the patient. We do that for 3 days, and then we decrease to about 2 milligrams per kilogram. And so if you'll see, this probably separates our protocol from almost anyone else's. It's very aggressive with the steroids. And if you read my paper on organizing pneumonia, you'll know that in that paper, it's been known for decades that fulminant cases of organizing pneumonia require pulse dose steroids. They've known this for decades. And if you see anyone in the ICU on a ventilator, that is fulminant organizing pneumonia. Okay, so that's one thing, is that so MATH, right? So methylprednisolone, higher doses, we pulse early. We're even pulsing earlier than we used to, because we learned that if you fall behind these patients, they are impossible to recover. And so we try to get ahead of them and get them better before they get worse. We also use high doses of IV ascorbic acid. And I'll tell you, we have been increasing that dose. We started out with 3 grams every 6 hours. We found it wasn't really working, especially in the more severe ones. And now when we have really fulminant cases, we're using what's called megadose IV vitamin C. There's some increasing reports that came out of Australia showing these very high doses, not only in animal models, but even in a COVID case report, showing this dramatic response to oxygenation to very high doses. And so we are now using, so Joe Verone, one of our group in Houston, he's been doing megadosing now for, I don't know, maybe 6 to 8 weeks. Just incredible results. In fact, Betsy referred to actually one of the videos that's coming out about a physician couple that we rescued with the Math Plus protocol. It's a really cool story of how well he rebounded. We actually believe it was the megadose of vitamin C that turned him around, and one of the main ones. We use a lot of IV thiamine. It's good for many, many different reasons in critical illness. And then the other mainstay of our protocol, which is heparin, right? And so we've always been aggressive with anticoagulation. We've actually now amending this. So we used to start with sort of half dose heparin on the floors and then increase it as patients got sicker. Then we changed it to using D-dimer, but now we're going to update this. So just so you know, this is not fully updated. Based on recent data, we're actually going to be recommending full dose heparin on any hospitalized patient. That's what the most recent data shows, is that it is life-saving if you start early and aggressively. So everyone in the hospital should be started on full dose anticoagulation. There is a signal for harm in ICU patients, but we believe that's if you start it that late in the ICU. So if you start it early, you would just continue it into the ICU. So again, that's an update that will come. So you'll see that on the website. And then last but not least, I should never forget, Ivermectin, a huge addition to our protocol. And just so you guys know who are listening, right? I'm talking about our protocols. Let me make a key point about our protocols, is that they are meant to evolve. We go along with the data. We follow the data. We follow the science. As we find more and more effective therapies, we're going to add them as we see fit. If we think they're synergistic or additive to what we already have, we will. And sometimes we might remove something if we're not satisfied with the data. So if you want to know what our latest protocol or approach to treating this disease, always visit our website. Okay, so that's sort of the core components, which is math as well as ivermectin. And let's just go into my point about this dexamethasone business. So the reasons why we like methylprednisolone is a couple. So number one, methylprednisolone is known to have and reach high concentrations in the lung at prolonged durations. We have decades of trials of methylprednisolone in all forms of lung injury, so it's very common to us. Dexamethasone really only has a couple of trials that came out in this past year. We have decades of use of methylprednisolone. And the other thing is, in this gene study, which showed gene activation patterns of SARS-CoV-2, the drug that most closely matched or counteracted the gene activation patterns of SARS-CoV-2 was methylprednisolone, far better match than dexamethasone. And you can see that in this trial. So what in this slide shows what's called number needed to treat on the right. So if you look at the impacts in mortality when you use methylprednisolone, now some of these differences are driven by differences in dosing, but you'll see a consistent pattern. A number needed to treat to save a life of 2.7 means it's an extremely potent medication. For every 3 patients you use it on, you save 1 life. That's almost like defibrillating someone who's in VFib. That's how powerful it is. But if you look at the number needed to treat in these methylprednisolone trials, you'll see that they're generally under 10. Look at the recovery trial for patients on oxygen. To save 1 life, you'd have to treat 29 patients, and around 9 if you're on mechanical ventilation. So certainly nowhere near as potent as methylprednisolone. Same thing with hydrocortisone. Just recently, now we're having even more evidence to validate our choice of methylprednisolone. Here is a randomized controlled trial just got posted out of Iran where they actually compared methylpred versus dex. Now, You can argue whether it's the drug or the dose, because certainly 2 mg per kg of methylpred is higher than 6 milligrams of dexamethasone. I don't care what it is. I'm just telling you, on 2 mg per kg methylpred, mortality was so drastically reduced that the number needed to treat to save a life versus someone who's using dexamethasone is 5. So every 5 patients that you use 2 mg per kg methylpred versus this anemic recovery trial dose of 6, you're going to save a life for every 5 patients. And then similarly, in another cohort trial out of UCLA, actually my friends there wrote up this paper. I know that division really well. They also showed a dramatic improvement in survival if you use methylprednisolone doses. And so I hope you guys aren't confused which corticosteroid we like. Now, the rest of Math Plus, we have sort of these adjunctive medicines that we think help interrupt not only against viruses, but inflammation. And they're oftentimes some of them are synergistic actually with each other and with some of the other elements that are in our math protocol. So things like vitamin D. We prefer calcifediol if you can find it, because it's the most rapidly convertible into active vitamin D. And there's a trial there showing actually a drastic improvement in outcomes if you use it. So we use statins for its anti-inflammatory properties, melatonin similarly, as well as antiviral. And then we use high doses of zinc in the hospital. Famotidine, the jury's still out. There is some encouraging evidence on it. It's probably that we need higher doses, and we will update that as we go along. And then the other thing that almost exactly no one knows about, you have to read our paper to go over this review, but when we have refractory cases, we have rescued a large number of patients using plasmapheresis. And so that's what we call salvage therapy. If we get the patients too late or they haven't responded to all the elements of Math Plus, we do plasma exchange. And we've seen just dramatic responses. And in our review paper, our Math Plus paper, which was published a couple of months ago, there's a whole section showing the data around plasmapheresis. So I invite you guys to read it. So that's our Math Plus. We've been doing that since the beginning. We've had a couple of tweaks since then. And then, as you guys know, now we're like the world's ivermectin experts, right? We were following all therapies, all trials for months. And Dr. Marek is the one who first saw the signal around ivermectin. He saw a few trials. He thought they were really impressive. And they were showing signals that we weren't seeing around a lot of the other therapeutics. In fact, almost all the other therapeutics were failing in trials. And ivermectin just showed small trial, larger trial, prophylactic trial, early trial, late treatment trial, and they were all consistently positive. And so we started to just amass all the data. I rewrote our manuscript. Betsy talked about it. It's days from publication. At least that's what they keep telling me. But that's going to be available for the world to digest. It's up on a preprint server there, and you can look at it. But again, it passed through 3 rounds of peer review. Now, after we posted our early manuscript, I think it got attention to ivermectin because the WHO, they had hired someone to look at repurposed drugs, Dr. Andy Hill, and he started to look at ivermectin in late November. And the same thing happened to him that happened to us and Paul, which is he saw this signal that was getting stronger and consistent and reproducible. And now his whole team, since late November, have done nothing but research ivermectin. They have a network of communication with all 56 active principal investigators of all randomized controlled trials in the world on ivermectin and COVID-19. And he's putting together that data. As of today, he has 23 randomized controlled trial data with about almost 4,000 patients. And he's putting that together to present to the WHO, and we'll see what happens in the next few weeks to a month. And so, as you guys know, based on what we found around ivermectin, there I go again. I got invited to give testimony in the Senate. I gave another round of testimony telling the world they need to use ivermectin. I don't know, Betsy, you think I got it right the second time? I got it right the first time, just saying. I have a little resentment. I'll just tell you guys a quick anecdote, but there was an article written in the New York Times Magazine by a journalist who covered like all of these drug wars that the doctors were getting into fights. Let's use this and let's use that. And they profiled me in this article. And when the journalist asked the editor of the New England Journal what he thought about my advocacy for steroids, he said, I think he just got lucky. So who knows? Maybe I got lucky twice, or maybe it's just not luck. We'll let history decide. But as you guys know, and Betsy talked about, we went to the NIH with that data after my testimony. We presented to them, and they updated their recommendation, right? So now they have a more neutral recommendation. They no longer recommend against. I actually think That's a really unfortunate. I think it was a missed opportunity to save a ton of lives by had they given even a cautious recommendation. And so, and then Dr. Hill also, he has a meta-analysis which he posted on a preprint server showing really dramatic benefits in numerous important clinical outcomes, not the least of which is survival. 75% absolute reduction in mortality. Say no more. 17 randomized controlled trials, 2,100 patients. When are we going to get to sufficient evidence? Everybody says insufficient evidence, and I'm tired of it. Tired of it, Betsy. You hear me? I'm tired of it. All right. So
you can hear me now, because you're going to love this. Today, the NIH, we have hot news. The NIH came out again, updating its recommendation, the same recommendation. There are insufficient data for the COVID-19 treatment guidelines panel to recommend either for or against the use of ivermectin for the treatment of COVID-19. Results from adequately powered, well-designed, and well-conducted clinical trials are needed to provide more specific evidence-based guidance on the role of ivermectin in the treatment of COVID-19. Still the same old thing. Well, you got it updated. You know,
we'll get them. We'll get them. I don't know when we'll hit that level, but we'll get them. Okay, so then let's go to, and then, now everyone's talking about they want a big trial. Sounds like Oxford might do a big trial. We actually think it's unethical. I think based on the data, which we find convincing, the totality of the data shows that this is absolutely a life-saving drug. And so to do a placebo-controlled trial on a life-saving drug, you are running into some really ethically troubling waters. Now, everyone will argue with me, you can't prove that it works unless we do a trial like that. Yes, we can. I've already been proven that it works. I know it works. I've seen the data. The data is absolutely convincing. And so, but apparently not to the NIH panel. We've talked with the Biden COVID task force. They have told us that within the NIAID, which is part of the NIH, now there's a new work group formed just solely devoted to ivermectin. So we know that there's action afoot in the government, and we know that ivermectin's being looked at more, and so we'll see. Now, I'll just do a quick overview of our eye mask, which really centered around ivermectin. Just be clear that we know that there's 3 indications for ivermectin in this protocol. So number 1 is if you're high risk, which is elderly and or comorbidities. The data shows that you can protect yourself from getting COVID with ivermectin. And what you do is you take a dose today, a second dose in 40 hours. We call that a loading dose. And then you just take it every 2 weeks. And we find that's probably nearly perfectly protective based on the data. Similarly, if you just have a know of an exposure. So what some people do is they don't want to take it chronically. And they just, let's say you have a household member who suddenly tests positive or falls ill with COVID or brings COVID into the household, the whole household should take ivermectin, and you will drastically limit the chances of anyone else getting COVID. That's been shown in numerous trials. And then if you do get sick with COVID, our treatment protocol is different. It's a daily dose. Minimum of 2 days, maximum of 5, or until recovered. Many people are feeling better within 2 to 3 days, and so you don't need to take all 5. So keep in mind, there's chronic prophylaxis for high-risk folks. There's post-exposure prophylaxis in case you have a sudden exposure or someone in your household gets sick, and then there's the early outpatient treatment protocol. Everything's centered around ivermectin, as well as other immune supplements that we think is really predictive of better outcomes if you were to get sick with COVID. So that's eye mask. Now, we don't have a long hauler treatment protocol, but we are getting increasing anecdotes, as well as this small case series, which presented this dramatic impact on patients. So this Dr. Aguirre Chang in Peru, he took 33 patients that were sick for at least 4 weeks with symptoms after COVID. And after 2 doses, 88% reported complete resolution of all their symptoms. And then those that didn't, he gave them higher doses for another 2 days, and even a few more patients had total resolution of symptoms. And so, and we ourselves are getting increasing reports of people reaching out to us with these prolonged symptoms, and they take a couple of doses of ivermectin and they're just saying that, wow, do they feel a lot better. So hopefully we'll work on a protocol as we get more data going forward for a long hauler treatment protocol. Now, you guys want to have a laugh, although nothing about this is funny. And if you guys look at this slide, you might be overwhelmed. I'm going to wrap up. I know I have like 2 minutes, but give me a couple of minutes so we'll have sort of a morbid laugh. Okay. This is what's called a forest plot, and it basically shows treatment effects using these squares of individual studies. So each of these is a randomized control trial, and this was for scabies. So this is the meta-analysis of effects of scabies at 2 weeks of symptoms. This is ivermectin. So it showed an overall statistically significant benefit in favor of ivermectin, somewhat modest, about 65% improved risk or reduction in persistent symptoms at 2 weeks of about 35%, right? So pretty profound. But if you look, this is the amount of patients in the trial: 324 treated, 289 controls. The WHO approved ivermectin for scabies based on this evidence base right at the top. Okay, let's go to the bottom. That is the current evidence base for ivermectin in COVID-19. Look at the numbers of patients that we have in these trials. Look at the mortality benefit. It's not just about stopping itching after 2 weeks. It's about being alive. These profound, much larger evidence of mortality benefit from these trials here than in scabies. And yet, have they approved ivermectin for COVID yet? When are they going to do that? It was good enough for scabies, but not good enough for now. And I think Chris Martenson, when I was talking to him, he had that funny joke. He said, oh yeah, you remember that pandemic of scabies that cratered the world and shuttered economies and caused millions of deaths? And that luckily the WHO saved us from that pandemic of scabies. Yeah, so if you guys remember that too, maybe they'll do the same here with COVID. Last thing is, this is the paper, which I think is a historic landmark paper written by Juan Chimie, Jennifer Hibbard, and David Scheim. It is incredible. It basically shows the impacts on a population-wide basis when you widely distribute ivermectin. It can be found on our website. That's where it is. It's right here on the main page under News and Update. Please go and read that paper. Now, some more morbid laughs. The IDSA, Infectious Disease Society of America, last week, they updated their ivermectin recommendations. And guess what? They recommend, they like went back in time to where the NIH used to be, and they're recommending against use outside of a trial. Whatever. I am just so tired of this horrific skepticism against this evidence. Here's the funny part. They wrote this as far as a consideration. They write, in addition, there were concerns about publication bias as the available evidence consisted mostly of positive trials. What a joke. If you guys don't know what that means, it means that they're worried that the only people publishing are those with positive results. It is called publication bias. It is real. So how about this, IDSA? Do your job. Do your job. And why don't you scour the world's literature and the clinical trials registries and look for unpublished studies on ivermectin? Well, I guess what? If you're not going to do that job, someone else did it for you. This is Dr. Hill, consultant WHO. He has looked and scoured all of the clinical trials registry. He is not finding unpublished trials. So this concern that all of the trials are positive is idiotic. It's idiotic and unfounded. They're positive because they're positive, okay? And with that, there's more trials to come. Again, I don't know when it's going to satisfy the skeptics, but we know of, in general, some of the results of these are all uniformly positive. We don't have the actual data yet, but we know that it'll be available to the WHO soon. And the march goes on. There are countries and panels and ministries that are smarter than our IDSA and NIH, and they are all over the world, and they're increasing in number. This actually is not up to date. Most of Central America, much of Mexico now, increasing amounts of South America are approving it for use in their guidelines. And with that, guys, I'll stop. This is from our friends. They're showing like where there's some adoption versus full adoption. And so we want this whole map painted green soon to protect the global citizens of the world. And with that, I'm going to stop. Thanks, guys.
We just want to save lives. That's what this is all about. And we do have some questions. Karen Levins has a couple of them for you. One real easy one. Will the list of peer reviewers of the Frontiers in Pharmacology paper be readily identified? They will, won't they?
Yeah, so that's a great question because in my career, I had never heard of peer reviewers' names being made public, but Frontiers in Pharmacology, the journal that we published in, it's right on the proof. It's going to be available right there for all to see. There was 4 peer reviewers.
Well, this is good. She's got another question. And do you have a name for the Mexico kit? That she's familiar with the Ziverdo name, would love to push Mexico name here in Canada using NAFTA, USMCA as a catalyst.
Ooh, I think that's a great idea. I don't have the name of the kit, but if you, just Google it, because I saw a picture of the kit that they put together today when I was Googling other stuff. So I'm sorry, I don't have that exact name, but it's definitely being used throughout Mexico.
Now we have another question. This is Michael R., who wants to know, do we know of any hospitals in New Jersey that will utilize the Math Plus protocol?
Yes. So Eric Osgood, so I know of at least one. So Eric Osgood of Mission Hospice in Trenton, New Jersey. He's on our website. I believe his hospital is there, but he's the head of the hospitals there. And he's been using Math Plus since the beginning. He's one of our Alliance members. And yeah, if you get anyone real sick, I would go see him. In fact, that's where I would go if I was in New Jersey.
That's in St. Francis in Trenton.
St. Francis, that's what it is. Yep. Thanks, Betsy. Yep.
And let's see, Camellia Beatty, can children take ivermectin? What is the IMAS Plus protocol for children versus the published protocol for adults? And I have to remind you before you answer that, I forgot to say, folks, see your doctor. We can't tell you exactly what applies to you individually or your children individually. You have to discuss anything that we're talking about. This is for your education. But
totally agree. Yeah, no, thanks for reminding us that we don't want to, make the mistake of giving specific medical advice. We'll give medical recommendations and share our knowledge, but it's not meant for a specific patient. Ivermectin has been used widely throughout the world in children. So we do believe, and we don't specifically call out children, but you could treat a child with it. We don't recommend prophylaxis with children. You remember, we really only recommending prophylaxis for high-risk individuals, and children really are not high risk. They fare this disease quite well. It's as you get older that you do poorly. So no prophylaxis for children, but I would do post-exposure and or early treatment with ivermectin.
Philip Comerford would like to know, how does the FLCCC update the current mortality rate on iMath Plus? On the protocol. He remembers a table with circa 5% mortality compared to a mid 20% on many other hospitals.
Yeah. We have been, that's a mess. So we have not done a good job of updating that data. Paul Marek has not been able to access really current data at his hospital over recent times. Joe Verone has updated data. The last time I saw was on several hundred patients. His hospital mortality was around 11 some odd percent. But you have to understand, Joe gets really sick patients, and many of them in transfer and late phase disease. And so, those mortality rates are changing. But no, we have not updated. We just have not been able to have a good command of up-to-date data. Joe is overwhelmingly busy all the time. His whole team is. But I know there are people looking at that data. Hopefully we'll have an update soon in maybe a few weeks, because he did hire some data collectors recently. Actually, the FLCCC helped support some research assistants for him.
William Niels wants to know if Math Plus is available in Florida, and ivermectin has been used in Florida. We know that, right? That study that was done in Broward County?
Yep.
Right?
So we are learning. We have a whole and rapidly growing list of hospitals that use ivermectin. So that's becoming more and more common. While the governmental agencies are being very, very cautious and very slow in their recommendation, a lot of hospitals, just like a lot of countries around the world, are just going ahead and adopting it. So we know of ivermectin. Math Plus is different. I don't know of hospitals outside of our group which formally adopted Math Plus. In Ukraine, we do, but in the US, we don't. But this is what I feel about Math Plus, is that individual doctors are using Math Plus, and we know that from our Alliance members, people who talk to us from around the world. And so I wouldn't say they're in the closet, but I think they use it more in an independent manner rather than on an institutional level. So you could find doctors using Math Plus or aspects of it probably anywhere. I hope that number is growing, but I can't tell you like which hospitals formally adopted it.
Somebody, William Niels asks again about any evidence about long-term use of prophylactic ivermectin.
Yeah, so we want more data on that, but what we have are, so Hector Carvalho, kind of the ivermectin expert in Argentina, he did those two big prophylaxis trials, and he has healthcare workers who did 10 weeks of weekly, then a 4-month drug holiday where, the tissue concentration he believes is sufficient to protect you. In fact, he's reporting that people during that 4-month holiday did not get sick. And then he has them do another 10 weeks. So he has a lot of healthcare workers who are on their second round of 10-week stretches, no reporting of any significant adverse effects. So that's one piece of data. I know anecdotally of increasing numbers of people who've been prophylaxing throughout COVID, actually large groups, including myself. Now I'm probably in my 3rd month. And then we have case reports of doctors trying it actually in AML, where they gave it to children with severe relapsed leukemias, and they gave them high doses of like 1 milligram per kilogram, in one case up to 6 months with no adverse effects. So, and we don't have like the most rigorous data for long-term use, but we have not found a signal of danger or risk to it.
This is good to know. Let's see, we're getting a little more political here. Who controls the supply of ivermectin, and is it being hoarded by any particular entity?
So we have no evidence of hoarding. The supply. So we know a little bit more about U.S. than anywhere else. I mean, there's manufacturers of ivermectin everywhere, right? So in this country, as far as the FDA approved product, 99% of it comes from a company named Edenbridge Pharmaceuticals in New Jersey. They're highly regulated. They have a very pure product of oral tablets. But there are lots of compounding pharmacies that can actually compound ivermectin. Quality not assured, they're not FDA approved. So the big sort of franchise pharmacies like the CVS's, Duane Reed's and all that, they all generally buy from Edenbridge. And we know from them that the demand has spiked. I think they were up 12 times normal by December. And now they're like 1.5 times that. So they're like about like 18 times normal pre-pandemic usage. So the amount that's being used in this country is rapidly increasing. But there's not a shortage yet, and they are making plans to try to meet demand if, we hope, a recommendation comes from the gods of science and knowledge. I should say we're the gods of science and knowledge, the other gods of science and knowledge.
We have another political question here. This is from Rita Whitman, who wants to know, given pharma's powerful influence within governmental agencies, do you think the resistance to using ivermectin is due to the comparatively lower cost of our protocols?
So all I will say, I just want to be careful around that. Don't want to sound like a conspiracy theorist, but clearly, let's just talk about in an objective manner. There are clear incentives for ivermectin not to succeed in the quote unquote marketplace, right? Because if it's as effective as we say it is, it would make the need for a lot of their expensive pharmaceutical competing products to rapidly decrease. Let me just say that there are incentives. I don't want to go further into specifics of what they're doing or how malevolent their behaviors are. I don't know. I'm open-minded to the most benign explanations, and I would consider the most worrisome explanations for their behavior. And the truth is probably somewhere in between.
I'm afraid that's going to have to do it. We have more questions, but we can't get them to them this week. Dr. Corey? Thank you. That's all the time we have for now, folks. If we didn't get to answer your question, we will be back next week. We're going to do this we're going to do it on Wednesday nights. So if you didn't get it tonight, Try us again next Wednesday. And that's going to be 7 p.m. Eastern time, 4 p.m. Pacific, and whatever it is in between. In the meantime, we would love to have you join our FLCCC Alliance. You can do that by just going to our website, which is https://flccc.net. Go there, you just look on the network support page, and you can sign up. And then you'll get regular email updates from us on all this stuff that is happening. And in the meantime, we will simply be doing our usual thing, which is putting patients first. And thank you for watching. We will see you next Wednesday.